Welcome to the Ramalingaswamy Center's Colloquium on Equity and Social Determinants of Health. We are thrilled, we've finished 2 years of this, and we are thrilled to start our third year of the Colloquium series with KP, with Dr. KP. This was a well-timed, a happy coincidence that we have somebody who's speaking on mental health, given that just last week was World Mental Health Day. So Dr. KP is a faculty member at the Center for Health and Mental Health at the School of Social Work in the Tata Institute of Social Sciences in Mumbai. Prior to this, KP worked for almost a decade as a mental health service provider, researcher, and activist, and has developed mental health service programs in low-income urban settlements and institutions. KP's research, writing, and teaching is in the areas of mental health law, policy, programs and advocacy, LGBTQ mental health, clinical social work, and research methodology. They've written a lot of important texts in the Indian context on these issues. They are the author of Growing Up Gay, a critical psychosocial perspective, which was published in 2018, and lead author of resources on queer affirmative counseling practice as well as trans affirmative mental health care. In 2022, they edited a special issue of the Indian Journal of Social Work titled Coming Out of the Dark, Emerging Discourse on Queer Affirmative Mental Health Practice. They've been a visiting faculty at the University of Gothenburg in Sweden in 2015. And they have served on Government of India committees to develop status and planning documents for trans inclusion. They continue to advocate for queer and trans inclusion in institutions of higher education and mental health service spaces and the curriculum. We are excited to have you on today, Dr. KP. And with also a topic that we've actually not covered, managed to cover in the last 2 years. So this is whole new ground for us, and please go ahead. Before we get started, I just want to say that there is a Q&A box at the bottom of the screen. We encourage participants to please send in questions as and when the speaker is going on, and we will pick them up for discussion at the end of her talk, end of their talk. Thank you so much, Dr. KP.
Okay, good afternoon, and thank you very much, Dr. Abha, and to the Center for hosting this talk today. We've been in conversation for a while about doing this this talk, and I'm really happy that it's happened now. I mean, there were just too many things coming in the way, but it's Dr. Abha's persistence that has really made this happen today. So thanks for that, and great to have I could see 50 now. I can see 52 attendees, so it's a great place to begin. If we have about half of you staying with us after an hour, that would be even greater. So let me get started. I'm just going to share my screen and get us started on. Okay, so so like you can see here, this is more like an overview sort of a talk where I'm going to try and focus on 3 parts of the issue of LGBTQ mental health in India. The first one is, why is it important to talk about LGBTQ mental health? And usually, sort of traditionally speaking, when we talk about why and the rationale for doing something, we often start in a public health sort of approach. We talk about the magnitude of the problem. We say, this is the prevalence of mental disorders in this community. These are the problems of lack of service, barriers to care, etc. So that's how usually we approach the question of why. What I am hoping to do today is actually talk a little bit in the context of, why is it important? I'm going to actually go into what makes it possible to talk about LGBTQ mental health today. And so sort of the emphasis on what conditions have made it possible for us to talk about queer trans lives in the context of mental health in an affirmative, validating sort of way. So what is it about now, as in this time? Socially, politically, all of that, and also sort of what are the conditions that are making this possible. So that's the first bit of the talk. I'm going to spend, I think, a little bit of time on this, which I think gives context to how we are talking about LGBTQ mental health today. So I think that's the first part. The second part actually can be so much. And so I'm just going to do very little a snapshot of the what, which is, what are some of the conversations that are happening on LGBTQ mental health in terms of knowledge, research, action. So that's the second part of the talk. The third one is about how. which is how are we doing this? So how are we producing this knowledge? How are we doing this action? And this for me is a methodological question. And I can see there are a couple of people at least who are research scholars. I was told by Dr. Abha that quite a few people who attend these talk series are people who are doing research or early career researchers. So I think some questions in the section 3 which I'll raise, which are more to do with methodologies. So some epistemological questions about how do we do this in terms of knowledge practice. So that's the third part of the talk. So let's get started with the first one, which is what makes it possible for us to talk right now about LGBTQ mental health in the way that we are talking about it right now. So we have been, in that sense, in some ways, the whole question of, queer and trans lives have been around forever. They've been much more difficult in the past. They are difficult still for various reasons. And yet today we talk about them. And I'm just going to say two things here. One is we know that with many marginalized communities, and this is true of LGBTQ people as well, that two modern sort of tools of governance that are used, have been used with LGBTQ persons as well. And I'm going to tell you what those two tools are and why they're relevant to the conditions of our speech today on LGBTQ rights or health or mental health. The first one is law. It's an important tool of governance to do surveillance, to monitor, to allow, disallow, all of that. And we know that in the Indian context, of course, most of us would be aware of the criminalization of what was considered to be sexual relationships against the order of nature, which often meant that these were used to blackmail, criminalize homosexual persons. So we know that this was the British law that came up in 1860, and there was, I think, more than 2 decades of fight in the courts and a longer sort of collectivization and fighting on the streets and in other kinds of institutional contexts to try and push this law out. So there is the context of criminalization for many, many years. There are a bunch of other ways in which certain queer trans people or certain communities have been criminalized. So it's not just 377, something about which we talk, I think, the most. But there is, of course, the history of the Criminal Tribes Act, 1871, which was taken out after India got independence in the 1950s. If you look at the act is called Registration of Criminal Tribes and Dunaks. Okay, so this was, there's a very interesting book by somebody called Jessica Hinchy who talks about governance of gender in colonial India. And she looks at actually a whole bunch of laws that were actually meant to surveil a range of what were considered to be nomadic communities, and so therefore difficult to keep track of. And eunuchs is a term that's used, it's a biblical term that comes from the colonial context, applies to hijras and a whole bunch of indigenous trans communities in the Indian context. Similarly, you have other laws. So the Karnataka Police Act, interestingly, in 2012, suddenly inserts this idea of registration of eunuchs in Karnataka. We have the Telangana Registration and Control of Eunuchs Act, which was challenged in 2018. The verdict is still pending on that. There are a range of begging laws that we have, which are state level laws, which disproportionately affect certain kinds of trans communities that rely on arms, or what has actually been begging is again a colonial modern construct to talk about cultural practices around seeking arms. So again, some trans communities get disproportionately affected by that. Similarly, there is the there is a immoral trafficking, the IPTA Act, and now we have the anti-trafficking bill, which often equates trafficking with sex work. And again, certain kinds of communities from within the LGBTQ spectrum that are engaged in sex work are disproportionately affected by this law. So the point being that there has been a very, very long history of criminalization. And now that we are moving towards decriminalization, that forms really a very important background or a context in which today the queer trans mental health talk that we have in research, in academia, as well as in activism is possible in the context of what's happened around legal changes. The second tool, as I say, of modern governance is science, medicine, and pathologization. So saying that this is abnormal has been an old story, again, old story as in not just decades, but actually centuries old, of pathologization of certain kinds of queer and trans identities. And in some ways, criminalization and pathologization have worked in complementary ways, and which is why we are saying that they are modern tools of governance. So how they work in modern societies, they actually work in hand in glove and together in synergistic ways. And one very interesting example of this is in 2001, NAS Foundation India, which is an NGO in Delhi, you had an activist from NAS Foundation, Shaleen Rakesh. If you look up Shaleen Rakesh, NHRC, National Human Rights Commission, Shaleen Rakesh goes to NHRC about a young person who is being treated with conversion or shock treatment for being homosexual at AIMS Delhi, and says that NHRC as a Human Rights Commission should intervene, saying that conversion treatments have been considered to be barbaric practices across the world globally, and they are considered to be not only not effective in treating homosexuality, but actually considered to be a form of torture and should be stopped. NHRC at this point of time says, because Section 377 is on the statute book in the IPC, which means that being homosexual is a crime. So if the doctors in AIMS are actually giving this young person a chance to not be a criminal, then we cannot possibly ask them to stop that practice, right? So here is you have pathologization, which has changed world over, and we'll look at that briefly in a bit. But the law of the land, while the DSM and the ICD, which are the classification systems, have said long ago that homosexuality is not a form of mental illness. And yet, because you have the law, the NHRC, the Apex Human Rights Commission in the country says that, we can't possibly ask doctors to not engage in this practice because it's a criminal offense. So that's the sort of one example of how criminalization, pathologization have worked together historically in the lives of queer and trans people in India. So obviously, decriminalization and depathologization form, in that sense, the essential social conditions in which we are today able to do affirmative sort of talk on LGBTQ mental health, right? So I'm going to talk a little bit about this decriminalization and depathologization. So we know, of course, it starts with the 2018 Supreme Court judgment. Like I said, that we went to court, queer rights activists went to court for the first time in 2001. It was only in 2018 that we finally got the Apex Court, Supreme Court of India, saying that adult consensual same-sex sexuality is not to be criminalized. And so we had this verdict on decriminalization that came out on 6 September 2018. Interestingly, the verdict talks about role of healthcare, but also specifically counselors and mental health care providers in making lives of queer and trans people easier. So it does say that it is the responsibility of special skills of counselors to, enhance sensitivity, reduce stigma, help queer people, their families, workplaces, educational institutions, etc. So it's a very interesting, almost 500-page long judgment that has some important things to say apart from decriminalization, about queer and trans mental health. So that's the beginning in that sense of decriminalization, after which actually a bunch of legal things have happened in the Indian context, which form these suitable conditions, as I say, favorable conditions to talk about queer and trans mental health. Apart from decriminalization, the second thing is the passing of the Transgender Persons Protection of Rights Act in December 2019 by the Indian Parliament. Before this, there was another Supreme Court judgment, which is called the Nalsa Judgment 2014. But again, this law, which talks about a bunch of provisions around non-discrimination against trans people, has something specific on healthcare. Section 15 of this law talks about the importance of trans-affirmative mental health care, gender affirmative interventions, which include surgeries, medical interventions, and so on. Talks about role of counselors in the medical transition, surgical transition process. Talks about, for the first time, gender non-conforming children and their right to live with their families. And in some ways, in that implies that one will have to work as mental health providers with these young people and their families in affirming the trans identity of these young people and helping them navigate life and school and all of that. So the Transgender Persons Protection of Rights Act is a very, very important backdrop to look at trans mental health in today's times. The other event in that sense, and there are really a bunch of things that have happened, but that which is related directly to law, is this unfortunate incident of this young 21-year-old bisexual person from Kerala. Her name is Anjana Harish, who put out a Facebook live post somewhere around the first lockdown, COVID lockdowns around May 2020, March 2020. She puts out this post that her family has found out about her sexuality, and they're treating her against her will by incarcerating her in a mental hospital facility, which has people with substance use disorders and other kinds of serious mental disorders. And so she's being put here and is being treated with medication against her will, etc. Anjana Harish eventually does manage to get out, but she dies by suicide subsequently. And this led to a bunch of online response from both the queer rights communities, of course, from the community and NGOs and so on, but also quite a bit from the mental health professional community. And so one of the things that happened was a group in Kerala approached the Kerala High Court seeking a ban on conversion treatments. That is, treatments that are aimed to seek to cure people of their gender or sexuality that may not be normative. You had many actions happening, including almost every known association of mental health providers, whether it was psychiatric social workers, clinical psychologists, psychiatrists, all came out with statements against conversion treatment and said that we don't do it, nobody should do it. So it's actually a lot of momentum around this time, 2020, 2021, when we hear a call for stopping or banning conversion therapy. You then have June 2021. This is Justice Anand Venkatesh. For many of us from the queer community, is a big hero. Justice Venkatesh in 2021 June was hearing a petition filed by parents of one young person in Madurai. So this young girl had run away with her lover, another woman, and the family, which was quite influential, said that that this was a case of kidnapping and abduction. And so that's how the case came to Justice Venkatesh. He made this very famous statement when he was hearing the case. He said that I as somebody who has been socialized to believe that heterosexuality is the norm, often find homosexuality to be, this thing I don't understand. So he actually said, I'll go to a psychologist. And he did. He went to a psychologist in Chennai and took sessions and said that before I actually hear this case, I must first educate myself and look at my own prejudice before I speak about the lives of these two young men. So apart from showing this level of reflexivity, which is something that we all felt must be applauded, but one of the other things that Justice Venkatesh did was apart from speaking about these two women, he actually gave out a bunch of directions that have a very important impact on mental health practice. So one of the things he did was he talked about banning gay conversion therapy. The other thing he did was he told the National Medical Commission, so this was a directive made to the National Medical Commission to review its curriculum and remove any kinds of derogatory references to the LGBTQI community and have more affirmative information about the queer and trans communities to undergraduate and postgraduate medical students. So this was, as a result of that, the National Medical Commission put out this advisory. They also put together, in response to Venkatesh's Venkatesh's ruling, they also put together an expert committee. In 2022, this expert committee came up with competencies in specifically in certain disciplines like psychiatry, forensics, gynecology, etc., to revise the existing curriculum. So there's, of course, been more drama, and I'll talk about that in a bit, because recently in August, September, we are seeing some changes again happening in the NMC's position on this. But this, again, going back to saying that decriminalization and then a range of things happening in the courts that are affecting how we are looking at LGBT mental health. We all may be aware of the marriage equality petitions that the Supreme Court of India heard in April, and then they did, the judgment came out in October 23. I think I can see a hand raised. So I think I'm just going to suggest, if this is a mistake, that's fine. Otherwise, you might want to put out your question in the chat and I'll come back to it. Okay, so the marriage equality petitions that happened in the Supreme Court, Supreme Court said that you go to the Parliament to seek this marriage equality, yeah, I think there are a bunch of people raising hands. So I'm going to request you to put down whatever you want to say in the chat box. What I want to draw your attention here again is that psychiatrists issued a statement supporting same-sex marriage. This is before the Supreme Court's hearing. So this is again what I said earlier about decriminalization, depathologization. So the minute we have said that homosexuality is not a criminal offense, we see more readiness among mental health care providers to say that this is not a pathology. And we also see more readiness and willingness to engage in affirmative ways with queer and trans lives. So this is a position statement that the Indian Psychiatric Society came out with in April last year. Right. Okay, so before I go to the depathologization, my point about the decriminalization, and I think I will not spend too much time on this because this is just to sort of create background to say that until 2018, being queer, being trans was an offense, but things have now changed. And in this last 5-6 years, things are changing in a big way through courts of law, right? Then there is, of course, the whole story on depathologization of homosexuality and trans identities. Why is it important to understand? Depathologization, of course, is important for us to talk today about mental health, but also understanding the histories of pathologization in some ways is important for two reasons. One is that sometimes the fact that homosexuality and trans is no longer a form of mental illness is presented to us like some kind of a scientific progress, as if to suggest that mental health professionals and the side disciplines, which is psychiatry, psychology, psychiatric social work, we have been these super progressive, self-reflexive, self-correcting disciplines. But that's not how it works, right? So we know that depathologization is a very, very complex socio-political, legal battle that has been won after really decades of activism from within the queer rights movements, from within mental health professionals who are queer trans and allies who have really pushed for some of these changes to happen. So this is not a case of mere scientific progress, that we are such reflective disciplines that we change as times change, etc. The other thing is, of course, that when you look at pathologization and the history of pathologization, you are also able to see what are some of the disciplinary beliefs about what is normal, what is natural, and what is normative, gender and sexuality. So when you uncover these old beliefs or these sort of ideas that are there in the discipline about normal, natural, etc., while there might be depathologization of homosexuality or trans identities, there are these continuities in beliefs of what is normal, what is natural, sex and gender, right? And that you will see in many other ways. So, for example, how are paraphilias today understood within the mental health sciences? How are certain kinds of sexual practices like kink and BDSM and some of these sexual practices or even normative sexual practices, how are they understood can actually be viewed from, you can actually get a good insight on that when you look at the history of pathologization. So I'm not, like I said, not going to dwell too much on this, but just to draw your attention to as early 1900s, we believed that homosexuality was caused by female germ cells being found on male genital or male testicles. And so actually tissue transplantation from male genitals of homosexual men with testicular tissue of heterosexual men. So transplant as treatment, where you had heterosexual men's sort of healthy tissue being transplanted onto homosexual men. We've also had a history of, so from the genital origin or germ origin of homosexuality, there's also the idea that the hypothalamus in gay men is longer and somewhat like that of women, and therefore hypothalamiectomy, so reduce the size of the hypothalamus. And we've had, these kinds of surgeries that have been performed. After the 1920s, with the influence of psychoanalysis and so on, the shift you can see from the germ theory on the testicles to the brain theory to more non-organic and more of family pathology kinds of theories. So this is Irving Bieber, who is a psychoanalyst, who talks about a cold and distant father and over-involved mother being responsible for male homosexuality. And you have others who, for example, talked about in the psychoanalytic tradition, who have talked about childhood trauma, homosexuality being a phobic response. Freud himself was quite ambivalent, actually. He did say that everybody is born bisexual, but he said that all normal human beings, while being born bisexual, eventually, in the process of maturity and growth, sort of move towards heterosexuality. And there are some people whose sexual identity development is arrested, and that those are sort of homosexual people. So that's about. Bieber sounds like a Freud fan. Yes, Bieber is very much trained in the same psychoanalytic tradition. Rado, Bieber, some of these are new, sort of post the immediate, the sort of the first wave of Freud, neo-Freudians in that sense. So, like I said, the shift from brain, from genitals to brain to family pathology to then what we see in schools of psychology, actually, we see the influence of behaviorism around the 1970s, where there is a lot of influence to say that we should focus not so much on these interpretations and free association and those kinds of things that psychoanalysis talked about. We should focus on behaviors that are observable, that are empirical, that can be measured, etc. So that's when we hear about faulty learning. So growing up in a family where you have too many sisters, the boy becomes trans feminine or becomes sissy, or those kinds of ideas about faulty learning or sexual abuse during childhood leads to homosexuality later in life, etc. So behaviorism is the is the sort of ecological basis on which aversion therapies that we call today, or what are called as shock therapies, etc. So this is basically Volpe, who's a famous behaviorist who's doing this. Here you have a patient who's lying, a male homosexual patient, who's being treated with sort of electrodes that are being tied to his legs. So he'll be shown slides of men, and if he experiences arousal, he gets an electric shock. He's shown a slide of a woman, he does not get a shock. Idea being that the man will eventually learn to develop erotic attraction towards women, looking at women's bodies, and develop aversion to male bodies because he's sort of pairing that with the shock response that he's getting. So this is how we have come along from different causations of homosexuality to this point, which is 1973, American Psychiatric Association says homosexuality is not a mental illness anymore. Interestingly, this is not just a war of evidence, but also obviously a war of ideology. And there's a whole, I do a full course actually on history of depathologization of sexuality. So I'm not going to be able to go into details of what was happening socially around this time that brought about this moment. But I must refer to this, that this declassification happened as a result of voting. And voting, which was like this, 58% for, 37% against, and some people abstaining. So there's a very interesting paper, and I'm not going to go into details again, but this is a paper that actually compares removal of Pluto from the class of planets and homosexuality from the class of mental disorders. And basically does a very interesting take on how does ideology, power, etc. operate when it comes to scientific debates, and where scientific evidence and contradictions in scientific evidence often are resolved through ways that are not necessarily to do with what we consider to be evidence-based stuff. So it's very interesting stuff if you would like to read this. But this is just to give you sort of a background to say that we've come from like early 1900s to where we are at now. So today, when I go to the slides on what of LGBTQ mental health, please remember this this context of how this has happened, and how have we come to the point of depathologization, and in some ways now moving more towards affirmation. A similar story with trans identities in the clinic. So early archival research tells us that sexuality and gender were sort of conflated, and in some ways homosexuality was seen as a form of gender inversion. So people who were homosexual, they were seen as people who were moving away from their gender script. So a man who's attracted to men was seen as somebody who's actually feminine, right? So that is how you see sort of the origins of understanding of, so it's actually sex, sexuality, and gender all come together in the way this has been understood. Krafft Ebing is this guy from Austria, Psychopathia Sexualis, who used this framework to talk about cross-gender identification. So he actually makes a distinction between individuals who had a strong preference for clothing of the other sex to those whose feelings and inclinations became those of the other sex, and then those who believed themselves to be the other sex. And so Kraft Ebing says that the last category of people had a delusion of transformation of sex and was a form of psychosis, right? So this is how transness was viewed. There were two opposing views on trans identities for a very long time. One which believed that since these people's, their mind or their gender, as they felt it, did not match their bodies, we should help them by changing their bodies to, help them with hormones and surgeries, etc., so that the body can become congruent to their experience and their mind or their knowledge, their identity of gender. The other view, of course, was that why don't we change their mind? So instead of changing the body, convert them, change the mind of this person to say that, you're actually mistaken and there's something deep-rooted, deep-rooted trauma because of which you think of yourself as being, the gender that is not the gender that's given to you at birth. So this is in some ways the history of trans identities. Interestingly, after homosexuality was removed from the DSM, 7 years after that, transsexualism entered the DSM. Later, we see that transsexualism became gender identity disorder. More recently, in 2013, not recently, but the latest edition of the DSM that we use now, GID has been replaced with gender dysphoria, which is to say that the idea of disorder has been taken out and the focus is on dysphoria or distress that trans people experience because of the gender that they are given at birth and they don't get along with this gender. The ICD-11 that came out in 2022 now uses gender incongruence and in fact has removed gender incongruence or being trans away from list of mental and behavioral disorders and has included it in the sexual health chapter of the ICD. So that's a complete, what can be called as depathologization. It's no more, even to say dysphoria, it's no more a form of mental illness, right? So that's the story of the decriminalization and depathologization that brings us today to this point about what do we know about or what are we doing about LGBTQ mental health in India, right? This is what I'm going to now share in a bunch of slides is obviously not an exhaustive list. It's just a few pointers to say that a lot is happening. And actually now in the last 10 years, there's a great deal that's going on. So I'm just going to give you a few, so that it's like just a few notes, as it were. To start with, of course, with the fact that in India, with all the WHO and APA depathologization debate, 1973, DSM change, etc., in India, we didn't do anything. So mostly Indian mental health professionals are silent. There's a nice paper by Suresh Parekh that looks at representation of LGBT issues by mental health professionals in India. And he looks at two official journals, one of the Clinical Psychology Association and the other of the association of the Indian Association of the Psychiatrists, so IPS, Indian Psychiatric Society. And what he finds is that between 74 and 2000, in about 829 papers published in the IJCP, only 2 spoke about homosexuality, both were about conversion treatments, and 4 in the Indian Journal of Psychiatry, all were about conversion treatments, right? So we were not really engaging on the whole, is it pathological, not, all of that, right? We just basically said our culture. Otherwise, we follow DSM, ICD, everything when it comes to treatment of schizophrenia and OCD and all that. Here we said, acha, ye to Western hai, it's nothing to do with us. And we continue to do treatment for homosexuality, right? So, and this is not really a conversation in the Indian context, but that's changing rapidly. And now if you look at the scoping review, from 2010 to 2021. Now remember 2009 is the first time Delhi High Court decriminalized homosexuality. Yeah. And in some way that's an important time around which time mental health professional bodies, etc., people sort of started to come around to say, okay, we don't have to think of this as this terrible illness that needs to be cured. And so Chakrapani and others have done this scoping review. They looked at 14 databases. They found more than 3,000 articles and 177 were eligible according to the inclusion criteria. And this is what they share with us. There are many more quantitative studies. Most studies are focused on MSM, men who have sex with men and gay men, and on transgender women. and then some on both these populations. Very few studies on lesbian, bisexual women, and even fewer about trans men, right? The obvious reason for this is the HIV epidemic, the HIV-related, epidemic-related funding, international funding, number of organizations, number of research studies, all of that came up, which named gay men, men who have sex with men, and trans women as target intervention populations. So obviously, a lot of research that you have is also focused on some of these groups. Another thing that Venkatesh Chakrapani and others point to is that there is much more studies on HIV STIs. There is high levels of mental health burden due to stigma, discrimination, violence, and victimization. And there is non-availability of gender affirmative medical care, medical surgical care in government hospitals. So that's one of their findings. And they suggest that it's important to include the groups that have been missing from the LGBTQ spectrum and move beyond HIV, look at mental health and non-communicable diseases, look at the lifespan. So also look at older queer people, etc. So that's one of the systematic reviews. There are a bunch of others. You can take a look. This is specifically focused on mental health. Look at 60 articles. There are many of these studies are focused on prevalence of mental disorders. Some are looking at risk factors, protective factors, role of stigma, discrimination. Some have focused on intimate partner issues, couple issues among queer and trans people. Internet, both as playing a positive role in terms of finding community, reducing isolation, and also playing a negative role in terms of poor self-esteem. This is a study associated with dating apps, right? These are all, I'm only referring to systematic reviews. This is a systematic review on stigma and health, more than 50 studies that have been looked at. I'm not going to go over this just for you. I mean, just a snapshot to say that a great deal of research is now happening on queer and trans mental health. Pandemic, if you just look at I mean, this is just a snapshot of a Google scholar, there are many articles. How has the pandemic, COVID-19 pandemic affected LGBTQ community, health, mental health, access? There is something on the graying minorities, older queer and trans folks, and how has it affected their lives. Social support, resilience coping, families, all of those are also important sort of variables and that are being studied. One recent study that was completed by Sangat Gopal is looking at older queer adults about 50 years of age. There are a bunch of these initiatives here in Bombay, Himsafar Trust. Calcutta, Sappho for Equality has recently finished a study looking at older queer folks and mental health, social support, aging, how are some of these things working in people's lives. I'm just going to give you two examples of things which are happening outside the research or academia, that kind of community. And this is a good example of a network, a national network on lesbian, bisexual, intersex women and trans persons, along with PUCL, which is People's Union for Civil Liberties. They together organize this closed-door meeting, something that we call Jan Sunwai, that maybe public health folks are familiar with. So this was a Sunwai that happened with a bunch of 8 sort of judges. They included like retired judges, lawyers, human rights lawyers, activists who are working on women's rights, queer rights, gender studies scholars, etc. And this was basically put together. This report is called Apno Ka Bahut Lagta Hai. This is about familial violence faced by queer and trans people. And this was used as a backdrop. I mean, this was used in the marriage equality petition. If you know about the Supreme Court marriage equality petitions, there were about 20 plus petitions that went to the court. One group of petitioners was this network and people from this network who were basically arguing not really for marriage, but for recognition of families of choice. And one of the arguments was that natal families are a huge site of violence and where physical health and mental health is seriously compromised, including suicide, non-suicidal self-injuries, and so on. So the need to recognize families of choice that communities make for themselves. And the need to not think of, because in law, often there's an assumption that you either are, in every sense, who will take decisions for you, if you're medically not capable, who will get your property, etc. There's an assumption that it will be your natal family or your marital family. But for queer and trans folks where natal family is often a source of violence, we'll have to recognize other forms of families, which need not necessarily be only through marriage. So this is an interesting, I just want to point to this because it's community publication, community research, community voices on what is urgent and what needs to be studied, what needs to be highlighted, what needs to be done, right? Similarly, another example of community action is this whole what is called as the NMC saga, the National Medical Commission. Suddenly in August said that we had done all these new competencies which were all queer, trans, inclusive. They're also very, very affirming of persons with disabilities, etc. Now those don't hold anymore. We will go back to the earlier sort of curriculum that we had, and this came as a big surprise, and a lot of activists sort of mobilized. It's a very interesting piece by Dr. L. Ramakrishnan from Sathi, Chennai. He calls it the curriculum content disorder and the sort of problems with the Indian medical education and NMC saga. So people sort of rallied around and have pushed the NMC to go back on this order that they have put out. But the new competencies that the NMC has put out still has some, old references to gender identity disorder and things like that. So some of that is something that will have to be looked at. So this is just to say what is it that we know in terms of systematic reviews, scoping reviews, things that the community is doing on LGBTQ mental health. I'm just going to go towards the last bit. I think we're doing okay for time. So the 10 minutes is what I will take. I can see there are a couple of, again, hands raised. I will come to questions in a bit as soon as I finish this. We'll see some questions. Okay. All right. So the why, the what, and now the how. The how, as I said, for me is a question actually of methodology. That we are now talking about queer trans lives. We are talking about LGBTQ health, which is even beyond HIV. We are talking about mental health. We are talking about mental health not just in the context of conversion treatments and how they need to stop, but we are talking about mental health in terms of, practice, affirmative care models. We are talking about how to enhance, how to reduce barriers to care and so on. So all of this is going on, but I think some questions about how we are doing this on methodology, I think are important. So that's what I will try and dwell upon a little bit here. And I'm going to start with the favorite, which is researcher positionality and of course reflexivity. So who are you? And who are you and why do you have this question? So where do I come from and where does my research question come from is really in some ways a starting point. Why is that important, particularly with queer trans lives, is historically research about our lives has been done in what Laura Nadar, who's an anthropologist, she talks about studying down, which is basically the knowledge producer or the researcher comes from a dominant community. They are experts. So they are dominant community, meaning socially dominant community, but also because they're experts, they are the dominant community. And they are studying a vulnerable and a marginalized community. So she calls this studying down, right? And in the context of LGBTQ lives, as we saw, many times our lives have been studied by people from medicine, from side disciplines, from law. So these are outside experts who have talked about or pronounced on the realities of our lives, from where we have these theories about germs on the genitals and childhood abuse causing homosexuality and such like ideas. So therefore then, who studies whom? Is this studying down? The opposite of that being studying up. So the marginalized communities study mental health professionals. The marginalized communities enter into a dialogue with lawmakers, right? That's like a studying up. And so is that even a possibility when we are talking about knowledge production in queer and trans lives, in the context of queer and trans lives? That's a question to think about. Connected question is about this outsider expert location. That is, often the expert has been somebody who doesn't share the queer trans experience or identity, and therefore is an outsider, is an expert, who is setting the research agenda often. Right? There's of course a role of funding and So what kinds of questions are being asked? How are these questions framed? Yeah. So just one example is that for the longest time in mental health, we talked for more than, I think, 30 years, we talked about, is conversion treatment effective or not? And you had evidence created from this side and this side. Yeah. That there were people who were claiming often religious conversion treatment programs. So coming from a place of homosexuality is a sin and therefore needs to be cured. So conversion treatment programs which said that there is high possibility of being able to live as a heterosexual through using whatever conversion treatments to prayer, to whatever conversion treatment approaches that they were following. So there was evidence being created like that. And for a very long time, queer, trans, affirmative, validating, either people from within the community or researchers who were allies, were caught in creating counter evidence of saying that, well, conversion treatment doesn't work. Okay. And so these were really the evidence wars. And why I'm saying this is that if you change the research question, and which can happen based on the location of the researchers. So if you change this question from is conversion treatment effective or useful to saying what are the harms that conversion treatment causes, right? So you see a whole new vision and a whole new, reality that unfolds by changing the question or flipping the question, as it were. So it's very important then about who's asking the question, who's setting the agenda. Inside a location, having an intimate knowledge of the community that is being studied, who's setting the agenda, is the community that is setting the agenda. How does the same research question look different? So if I'm interested in looking for etiology or causation of what I consider to be abnormal gender, then I'm going to try and ask trans people if they have sexual abuse in their childhood and say that it was that which caused the gender incongruence later in life. As opposed to, if I'm going to say that trans people have extremely vulnerable childhoods because of their gender incongruence, there is often a lot of sense of alienation from their families, peers, even from their own bodies. And so these vulnerable kids are therefore more likely to face more number of adverse childhood experiences, including sexual abuse. Then it's a completely different way of asking that question, right? So this is, I think, some thoughts on philosophy of research in terms of primarily right now I'm staying with the researcher positionality. Insider research is often criticized as being biased or agenda research, as if to say that all other research which is not from the insider position is bias-free or neutral, and therefore more credible, scientific, etc. So while of course given rigor of research is one thing, but this whole insider-outsider position is something that I would like us to think about a little bit. Another epistemological question we hear often from, particularly among quantitative positivist researchers, the idea of distance between the researcher and the researched, that in order to maintain objectivity, neutrality, there has to be distance. And I think one must ask that if there is distance, that also translates into an experiential distance, that you have no clue about my life. And so therefore, a more empathetic ally position is something that will really help to bridge this experiential distance if you want to be able to understand anything about queer or trans lives. Of course, who's the insider, who's the outsider? There's a whole question of gatekeeping that community leaders are known to do. We've seen some of the ugly fights, even in the Indian context, about who's real trans. If you're a binary trans person, if you're post-op, only then you qualify as trans, etc. Trans women are often seen as the representative of the trans question. Trans masculine folks are often not seen, as much visibly seen as representing issues of trans people, etc. So this is about researcher positionality. I'm just going to give you two examples of my own work. This is a journal called Indian Journal of Social Work, and I edited a special issue in 2022. This, to my mind, is a good example. I mean, I'm not sort of at the risk of self-advertisement. What I'm interested in saying here or drawing your attention to is, so this is an issue which has 9 articles, all done by practitioners. Most of us who occupy queer trans locations ourselves and other kinds of marginalized locations in terms of caste. Many of us have had very close engagement with the mental health system as service users. So we live with diagnosis of mental illnesses, have been on medication, psychotherapy, etc. This is a good example of and this issue actually looks at, I mean, all out of the 9 articles, 8 articles are about practice. The first article by me is a more of a theoretical sort of article that's putting the whole concept of queer affirmative mental health into perspective. And then you have these 8 articles which are looking at various things from somebody who's done as a clinical psychologist, has worked with trans people for 10 years, and he talks about reflective practice and talks about how his practice has changed over the years as his understanding of transness has grown, as we have learned more and more from trans communities. And he actually sort of talks about the blunders he's made 10 years ago. You have other articles that look at cognitive behavior therapy with queer people. How do you contextualize it to the Indian context? You have another paper that talks about using narrative practices with young people who are below the age of 18, so adolescents who are gender non-conforming and who want affirmation for their gender. We have papers on couple issues and practitioners, how they alter their existing training on couple therapy to accommodate for the kinds of stressors that queer and trans couples bring in. We have an article on microaggressions faced by queer people in therapeutic settings. So from their therapists. So I mean, yeah, this is just to say that there is work like this that's being done from inside a reflexive position. I'm not at all advocating or saying that only queer people and trans people can study other queer and trans people. That will become clear as I go forward. But just to say that that's not what I'm saying at all. But I'm saying that we'll have to do some work on ourselves and also, develop some competencies to be able to work on queer and trans mental health issues. This is another example of a study that I recently completed, done in 3 cities of Bombay, Bangalore, Delhi, mixed method, quantitative, qualitative study. This is an example of, in some ways, what I was saying, studying down. In some ways, this is all of us who were part of this. There was myself and 3 other co-investigators. All of us are from the community. All of us are mental health professionals trained in actually non-medical mental health practice. Most of us have some mental health histories in terms of diagnosis, treatment, etc. And we have studied mental health professionals. So we are not studying trans people here. We are studying professionals, and we are trying to understand how are mental health professionals practicing with their trans clients in their clinics. Yeah. So this is an example, I would say, of studying up or studying side by side, as it were. That we are studying the dominant community in that sense. Cis, heterosexual, mental health professionals, experts, etc. Yeah. So, okay. Studying or studying queer and trans lives in some ways is also about challenging what are considered to be universal theories. So by foregrounding lives of queer and trans people, which are sort of what I call subjugated, I mean, it's been talked about within standpoint theory about subjugated standpoints and knowledges. In some ways, what we are doing is we are saying, so I'll give you another example of this book, Growing Up Gay in Our India, where what I'm doing is simply in one chapter, I'm saying that childhood discourses on childhood, whether it is in developmental psychology, lifespan studies, child rights discourse, etc., we are assuming this child mostly to be cisgender and to be heterosexual, to grow up to become heterosexual, or to have heterosexual fantasies. So this child in our mind is often a child in the nuclear family. So the child is in the nuclear family and is this cisgender heterosexual person, right? And this is there in mostly child development theories. And that's one of the things I raise here in Growing Up Gay, where I say that there are different kinds of childhoods. And so we will really have to think about childhoods as social structure, and how they are informed by. So this is just to say that that this is what queer trans mental health work can do and can be beyond prevalence of depression and suicidality and so on, which is important research. But I'm saying that queer trans mental health can also be looked at from all of these ways, where you are raising critical questions about disciplines, disciplines about the human condition, human beings, human behavior, etc. And who have been traditionally left out? What are the voices that are lacking or that are missing, right? Okay. The other are more, not so much epistemological, but more ethico-political questions, which is about research questions to be drawn from the communities. Community needs to be involved in research studies from the point of conceptualization to a point of dissemination. If you really want meaningful participation, do not treat community, queer, trans community. First of all, it's not a homogeneous community, but to not treat queer and trans communities as these places from where we excavate knowledge. But more of participation, more of partnership. Yeah, this is about research scholars who often write, and this is a friend who works in a NGO that works on queer and trans issues, tells me that they regularly get these. Can we get a sample of 30 from your NGO? We want to do this study on LGBT lives. And I think the minimum that researchers can do is actually, state where does this question come from and where do you come from? So sort of state something about your position. And it can be that it doesn't have to be at all that you're a queer or trans person. I'm a mental health professional. I see myself as an ally of queer and trans people. I have a best friend who's queer. All of this. So my engagement, how is it that I am involved with this research question, is the important thing. Mindful to be to be aware of over-researched communities. So particularly in the context of HIV and MSM and trans women. Finally, young people and research becomes difficult, particularly a lot of young queer people are not out to their families. If you're below 18, then parental consent, assent of the child, all of that. Trans people, a lot of trans people are seeking services below the age of 18. How do we understand these lives? Right now, mostly it is being done through retrospective research. So you talk to adults who are queer or trans and try and understand more about their childhood. So that's a big question. Finally, just some thoughts on good practice of researching LGBTQ persons, develop competence, know about queer trans lives, watch films, get to know people, go for pride events, read first-person narratives, autobiographies. This is a very, very important way to know about what are the debates around LGBTQ issues in your field. So it may be you're studying something to do with suicide, or you're doing studying something. I know that somebody wants to do HPV and trans women. Then find out more about what is being done in this field. What are the methodologies that are being used? What are the debates here? What are some of the controversies? Are there practice guidelines, ethical protocols? So in the West, for example, there are guidelines specifically to doing research on LGBTQ persons. In the Indian context, there are some thoughts, some articles that have been put up here and there. So develop these competencies, ensure participation, have community advisory boards, community-led steering committees. I know there are at least a few research studies in India right now which are following some of these good practices. Compensating people for their time and knowledge, should it be monetary, how much, how. I know one study, one of the things they did was building capacity of community members on research, so that they can do their own research studies as a way to compensate for the time that they have given to the research team. Acknowledgements, credit sharing, authorship practices. These are all things, of course, to think about. So with this, I'm going to stop. These are a few resources. I will just paste this in the chat. The first one is about glossary of terms. Often people have confusion about what should be used, etc. This is something Tamil Nadu government has published in the Gazette, and there are a couple of other Indian resources. I'll just leave them with you here, and I'll stop this point.
Thank you. That was, that was like a triple whammy of a talk. It was like a conceptual part, there was a research part, there was a methodology part, and this was really helpful to, and as you said, this is just the briefest overview, and one could dig into any of these spaces in a lot more detail. We encourage participants to put questions in the chat box. I think we've been saying that all along. I'm just going to start with a few broader questions to start with. So, right now, globally, there seems to be this really massive debate on trans-affirmative medical care, especially when it comes to youth, and it's become politicized immensely in different ways and towards different ends. What is the discussion or debate around this in India? I don't feel like I've seen or heard a lot about it at all.
Okay, so I was just actually reading some of the things that are coming in the chat. But yeah, debates around trans affirmative care. Sorry, just distracted by the
Yeah,
Chinese.
yeah.
I mean, a couple of things. One is that, I mean, the West, of course, there is, in some ways, a huge backlash that we're seeing now, which is to do with both political right and the backlash of that, but also because, you know, the transformative care models have been around for a while, people have accessed them, etc. And there is a certain amount of backlash against overall trans communities and then transition services in particular. I think in India, there are a couple of things. One is with the law having been passed. And if you see, the law was passed actually about 3 to 4 months before we locked down for the pandemic. You know, the COVID the pandemic lockdown happened. So it was December 2019. But after that, we've seen actually, so there is now a National Council for Trans People that has been put in place. The central government has put together a bunch of schemes. And one of the things that the law promises is that the Trans Act I'm talking about promises is that gender transition services will be made available in public hospitals. And we know that Tamil Nadu has tried some of this. There has been bittersweet experiences there. About 12 clinics, I'm told, are operational presently. In fact, just last week, I was in Chennai for a training that was sort of NHM Tamil Nadu and Sathi from Chennai and ATI, which is Association for Transgender Health India, Delhi. They put together this training of doctors of these 12 gender clinics on transformative care. So I think in some ways things are picking up here. There is, of course, the moral panic about you know what has been called as gatekeeping by mental health professionals. That you know we would want you to prove to us that you're really trans before we are able to give you a letter of what should be called as a letter of support for you to seek medical transition, if you want hormonal transition, I mean, sort of hormonal interventions or surgical interventions. So there is a lot of that gatekeeping. Our professionals continue to call it certification, as if anybody can certify anyone's gender. But we continue to say certification, and there are lots of experiences in our own study. Aryan is here. He was the co-investigator on the trans affirmative practices slide that I showed, the study we did in 3 cities. We found there also there is a lot of delay denial of these certificates that happens by mental health professionals. So I think we are in a place where there is some amount of readiness to receive transformative training. There is very little training available. And there is simultaneously, there is attitudes and I mean, you know, the idea that why are we talking so much about trans people now? This must be because it's a social media fueled fad. And you know, those kinds of things. I mean, it's a strange thing. I always say this, that in India or in our region, to say that trans is a contemporary or a fad, which is, you know, like a phenomenon of 2010s is a little strange. I mean, you know, we've Hijra, Zaravanis, Jokta, Shiva Shakti, you know, I mean, these kinds of communities have been around even before India as a country came into existence. So it's a bit strange to hear those arguments, but all that exists. And so too much of Netflix is leading to our young people wanting to see gender transition.
Corrupting our minds, right?
So that is there. So those attitudes are there, but there is readiness of training, you know, seeking training. There is some amount of efforts that are being made for, I think, Dr. Sanjay Sharma and API, the Association of Transgender Health India, Sangat in Bhopal, Dr. Aksa Sheikh from Jamia Hamdard in Delhi. Some of these people have tried to create what are called as medical competencies for trans care. The study that I mentioned, which is got 10 guidelines on trans affirmative mental health care, 12 guidelines, sorry. So these are some of the documents that are there. I think people are making an effort pushing for transformative care.
Okay. No, it's great to hear. Like you said, it's a slow progress, but it is happening in bits and pieces, and it's good to hear that. But I mean, but this still doesn't talk so much about children's. I mean, that's what is really politicized, right? Abroad, it's under 18-year-olds. What are we doing to their bodies? Long-term effects. The research is mixed, so on and so forth. But I guess we're not at that point yet. It seems like in the Indian context.
I think there are multiple strands. So one is that the WPATH, which is the World Professional Association of Transgender Health, has now what is called as a Standards of Care version 8, SOC 8. SOC 8 has a whole chapter on gender non-conforming children and adolescents. And they have a whole bunch of guidance on what should be done. I do know that there is some readiness among endocrinologists and psychiatrists in India to try what are called as puberty blockers for some instances where you have teenagers who have, had high levels of gender dysphoria, have experienced gender incongruence for a very long time, and with puberty, because with puberty, secondary sexual characteristics, all of that will mean that the dysphoria will increase very much, and there is suicidality and all of those things. So to avoid some of that, using puberty blockers, which is to basically stop puberty from happening till the person is able to, whatever, become a major or an adult and is able to take decisions about their medical, surgical care, etc. So there is some openness among some people, but there is a lot of resistance as well. And the resistance largely comes from the idea, what if you change your mind? Yeah, because
Right.
and which is why it's important to also sort of educate ourselves that many of these interventions are reversible. So puberty blockers, the idea is that if you stop taking puberty blockers, then puberty can progress. So, but I think there is partly ignorance, partly moral panic, partly the idea of sweet innocent children being corrupted. It's all of that like coming together, which causes a lot of difficulty. But I think some ways, and if I can take a minute to just stress this point for mental health professionals who might be listening here, is that our conversations around teenagers or minors who are presenting with gender dysphoria should not stop and be limited to medical interventions. Nothing should stop us from helping people do social transition. So if I want to be called by a particular name, I don't want my birth name or my dead name to be used. There's nothing stopping us from telling parents that, why don't you call this person this? This is their chosen name. Why don't you use this pronoun for them? Why don't you let them use the clothes that they want to use? Why don't we talk to the teachers and say, why that, this unisex type of uniform, or the uniform that suits the gender or works with the gender of the person, as opposed to the gender assigned to them at birth. So nothing stops us from providing these kinds of social interventions, or providing support for bullying that happens, or providing safe spaces where people can explore, young people can explore their gender identity. So I think our conversation shouldn't limit itself to hormones or no hormones. I think that becomes then, a no-go. And the child, poor thing, is then being told that तुमको hormones नहीं मिलेगा, तुम basically 18 साल के बनो, उसके बाद we will affirm you. It makes no sense. Like the child who is facing this level of dysphoria or alienation from themselves, from people around them, is really in trouble. And as mental health professionals working with children, we should absolutely do whatever we can to, support and validate this child.
Right. I think, I mean, as you pointed out, there seems to be this tendency to, it's all or nothing kind of approach. And as you pointed out, there's many intervening steps one can take to support the mental health of young queer people, essentially. I think questions, a lot of comments about what a fantastic presentation it was, and it truly was. I think for those of us who don't work in this space and are only peripherally aware of it, this was very, very detailed and informative. But a couple of questions now. I'm sure Ebhan must be Anand, but he asks whether you can speak to the role of intersectionality in research practice and advocacy, and the role of solidarity across communities. I think he perhaps, I don't wish to speak in his space, but communities, you mean like multiple, like you said, it's a very diverse community, the queer community, right? So how can you speak to some of these issues that he's raised?
I think two levels. One is, like I mentioned in the systematic reviews that have told us that certain subsections in the trans spectrum and the queer spectrum are underrepresented. So, for example, lesbian, bisexual women, trans masculine folks are underrepresented. And so that's one group that one needs to think about more actively. Intersections of other kinds of social locations. So I think I talked about intersection with being a mental health professional or being a mental health service user. So I could be somebody who is genderqueer, non-heterosexual. I'm a non-medically trained mental health professional. So I'm a social worker, I'm a psychiatric social worker. I am also somebody who has lived for a long time with a diagnosis of panic disorder, has used mental health service systems for a very long time. So these are some intersections of different identities. Similarly, other kinds of intersections, of course, are about other marginalized locations, like coming from a rural community, coming from a caste location that might be oppressed, coming from a class location, that disadvantages me. So these kinds of intersections along with queer, trans, etc. So in fact, I don't know if they are here, but one of my collaborators on the trans affirmative care practices, the project, somebody called Neeraj Kumar, who runs a project called Project Unsound, talks about this very interesting space of being Dalit, being trans, and living with a diagnosis of mental illness. So Project Unsound refers to unsound mind. So this is the intersection of caste, oppressed caste location, oppressed gender location, and sort of a patient identity, as it were. And Neeraj works with a lot of young people who have these identities. Who have a neurodiversity location or a MAD location, as it were, and who are queer, trans, and who are also from the Dalit Bahujan Adivasi community. So yeah, so I think all of these intersections, and I think when I was talking earlier about positionality, that's what this is about knowing that there are ways in which I am vulnerable and marginalized, and there are ways in which I am privileged. And what am I doing about my privilege? Do I use it to speak about other people's vulnerabilities and marginalization? Do I use it for my advantage and perpetuating my privilege, or do I use it in what way? So I think those are some of the things. I think even solidarity, allyship is some of that kind of work that needs to happen.
Thank you. Someone else asks, I guess, a more research and methodology kind of question about theoretical frameworks to study the mental health of LGBTQ plus populations. I think they mentioned that Myers minority stress is all that they usually see.
Sorry, I didn't get the question. Can you repeat that?
No, theoretical frameworks that are helpful to study the mental health of LGBTQ plus populations or individuals.
When I was talking about my book called Growing Up Gay, one of the things I was saying is that studying mental health does not have to mean studying mental illness. Yeah. If we are studying mental illness, then of course, some of the models like this broadly, what we call social determinants of mental health, and structural determinants and drivers of mental health is something that is very useful to understand why is it that queer trans people are more depressed, they're more likely to die by suicide, they're more likely to have substance use disorders, etc. So more structural drivers or social determinants or social exclusion kind of frameworks. But for example, I was saying about growing up gay, sort of critical. So one of the things I do there is I sort of look at mainstream psych literature on human development. Okay. So I actually, I have a sort of a heading which says looking for the queer child in human development literature, and then finding the queer child in the pathological sort of literature, psychiatric literature, right? So these are also lenses that you can actually look at. So similarly, if you look at all the family therapy literature that we have, couple therapy literature that we have, they are speaking about some couples and some kinds of families. I think I see Shailesh Vaidya's comment here about all of this knowledge theories, therapeutic methods are patriarchal, heteronormative, absolutely. And so to be sort of, so therefore, when we first spoke about, and I want to mention the work of Bhargavi Davar, who was one of my earliest mentors who passed away a few months back. When she first wrote in 1999, she wrote a book called Women's Mental Health, the Feminist Agenda. What she was doing was she was asking questions about the patriarchal nature of mental health sciences. And, 20 years hence, we are asking questions about the heteronormative nature of mental health sciences. And now we are beginning to talk about the cisgendered nature of mental health sciences. Because the science is like that, the theory is like that, the practice which emanates from that is also like that. And so we have to actually, in praxis, do some of these questions, and do some of these. So lived experience, learning from lived experience, social exclusion, some of these are, I think, ideas from theoretical positions to do work on transitions.
Okay. Okay. Helpful in terms of, if one were to design studies in this area, how one would approach these questions. Dr. Souvik asks, often parent-child relationship is looked at as a protective mental health factor. How does one look at it from, the perspective of queer trans individuals in India? How do they, I guess the published literature, what does it say about parent-child relationships with respect to the
Yeah. So was there a question about parent-child relationship as a protective factor?
I think he's pointing out that it usually looked as a protective mental health factor. So
Right.
how is it? How does it work in this research space? Yeah.
Yeah. So, like I said that I mentioned this report where you're saying that natal family often is a site of violence and not a site of protection or nurturance, which is one of the assumptions that we make about families, right? It's a very big assumption we make about families that all children are protected, loved, etc. And I'm sure it's not applicable to cisgender heterosexual children as well, very often. Yeah. I mean, it's not like family is this great haven and support to everyone. But I just want to point again to two theoretical ideas. One is that somebody called Alpert, I think Gordon Alpert, talks about this idea of being a minority. And being a minority, when you look at minority experiences in terms of class, ethnic minorities, religious minorities, etc. When it comes to queer people, we are a minority who are a minority even in our own families. In the other minority experiences, you are a Dalit person, you are a Muslim person, you have your family. I mean, it's a minority suffering and it's a minority identity. And I don't have to figure out on my own that why am I being badly treated? It's most likely that some adult around me will pick up and say, your best friend refused to eat food from your tiffin because of your religion. Or because of your caste. Yeah, somebody will pick this up. I will not be left too long to make sense of why did my best friend refuse to eat from my tiffin, and is that because I'm a bad person, right? And now that's something that happens with queer and trans people. That we are minorities within our own families, and so in that sense, yes. But working with parents, I think, is a very, very important area. Something that I have. I think people should really dedicate time and like your whole career in some ways as mental health professionals too, because I think in some ways cisgender heterosexual parents, well-meaning ones, are clued out as well. Yeah, I mean there are of course the ones where there is overt violence and where you have to look at crisis intervention and survival, but there are also instances where parents want to try and want to understand, and they really need support and they really need help and they really need knowledge and competence and awareness and all of this. So I think a lot of scope, and what we see through scoping reviews, as I said, that familial acceptance is a very important protective factor against all kinds of mental health adversities. So native families are a very important place for intervention.
Thank you. There's a couple of what occurred to me as slightly rudimentary questions, but about whether childhood trauma can be a cause, or how does one know whether they're lesbian, gay, bisexual, or trans. But I think there are perhaps better resources to look this up, and maybe we don't use this. Or
no,
would you
just,
like to?
I could just one line. How do you know you're heterosexual and how do you know you're cisgender? Right? Same thing. Yeah, if you know you're heterosexual in some way, similarly a homosexual person will know they are homosexual, right? Same pathways. And similarly about gender, everybody goes through a bad time in childhood. Most people grow up to be cisgender. Some people grow up to be transgender. Yeah. So in that sense, yeah, I mean it's childhood trauma, etc., causing non-normative gender and sexuality is something that is not something that has any. I don't want to say scientific basis because I'm so critical of scientific basis, but it's something that you should really sort of look at and think about. Yeah, what made you cisgender? You as in not the person who's asking a question. I don't mean to put anyone on the spot, but anybody who's cisgender, you should ask, what is my gender? How did I know this? When did I know this? Who were the influences? Same thing. Similarly for sexuality. Yeah.
I think that kind of reflexivity is worthwhile in any kind of research, frankly speaking, and especially so when you're working with marginalized communities. Lots of somewhat methodological questions about navigating outsider expert locations and intersectional identities. How does a researcher negotiate challenges of an individual's self-identification while conducting research? So lots of questions around these. I don't know if you can give a general answer. I think they all speak to some level of self-reflection. But if you want to add or expand upon some of the points, I think you had to hurry through that last bit a little bit. Perhaps you could expand a bit on it now.
So actually, in the last slide, I was suggesting this, that one is competence. So if I want to work on queer and trans issues, one thing I must do is I must know about queer and trans lives. So I shouldn't say that research is what will help me to answer these questions. Research is a much later step. I can, actually going and doing empirical research, I mean. So do your own research, read people's autobiographies, watch a couple of films. I tell all my students who are not from the community, particularly those who are not from the community, to volunteer, spend time with organizations that work on queer and trans issues, provide whatever resources you are able to provide. So you might be, able to do internship, might help these organizations, which are often small organizations, help them write research proposals and funding proposals and maybe put their data into Excel sheets and those kinds of things, but get to know people, have engagement, have real-time engagement with people. And then, of course, in a more structured sort of sense, having community advisory boards, which also sometimes can end up becoming just a token, no? And that's obviously something to be avoided. So you don't just bring 3 people and, they don't become your token lived experience experts, but you actually involve them in conceptualization, you involve them in every possible way. So I think those are some of the ideas, but competence is the first place to begin from. Self-reflexivity on where do I stand on questions on gender and sexuality? Do I have friends in my social context? I always say this, that if I don't know a single queer or trans person as my relative, as my friend, as my student, as my client, yeah, if that's happening, then you must really look at yourself for 2 things. One, am I safe enough? Then maybe queer trans people around me, they don't come and tell me. Okay, am I safe enough for these communities, for these people? Second, do I only engage with people who are like me? Like, do I have such a homogeneous social circle? Or do I engage with people from other kinds of social locations? So I think, yeah, it's work at personal level, it's work at the training level, it's work at the knowledge competence level, methodology level. And having advisors on board, particularly if you're new and you're starting young researcher.
Okay, fantastic suggestions, I think. I think I'm going to tackle 2 more questions here, I think, as we're winding down on time. Muskan, actually, I'd like to single out Muskan, who's given a lot of interesting comments as well in the chat. And KP will share the chat with you later on, because I think there's lots that you could respond to, perhaps, with people reaching out to you. But Muskan asks, as a queer person myself, how does one navigate consistent disappointments while working with medical systems?
Unfortunately, it makes the 2 of us. I'm with you on this, but how does it navigate? I think build community. Build community of one of the things I've been trying to do now in last 2-3 projects of mine is to find mental health professionals who are queer and trans. We need to have allies. There are some very, very, researchers who are allies, practitioners who are allies. Build community. So that we are also sort of a voice to contend with. We build knowledge. So our voice is out there. Don't do it alone. I think that's the thing about any kind of marginalization, any kind of marginalized experience. Try and build community, and it's like this, you find 2 other people like yourselves. It's almost like a mission, no? It's consciousness raising. You go to, I'm a teacher, I do a course on queer affirmative counseling practice. Every year, there are, 30, 40, sometimes 60 students in class. I'm hoping to build community. And I'm hoping that they will build more community. So this will be about consciousness raising. So such that this voice, the affirmative voice, becomes so loud that it becomes impossible to ignore it.
That's a hopeful and optimistic way to look forward. Dr. Ritika asks, actually, there's 2 questions and I'm going to link them here. Dr. Ritika asks how, they are asking about how an MD or microbiologist can be part of, work in this space. But I think I'll broaden it to, the biomedical space itself. What contributions can they make? So, conventionally trained doctors in the biomedical space, what kind of research can they do, or how can they contribute to work here?
Oh, I think hugely, because healthcare service, particularly mental health care service, is something that queer and trans folks want to access, need much more to access. So it's the most obvious, of course, is that trans people who are seeking transition services will need to access a psychiatrist or a clinical psychologist for being able to go ahead and go to the endocrinologist for their medical transition, go to a surgeon for their surgical transitions, and a mental health professional who can back them and support them all through this. So there's a lot that healthcare providers can do for mental health, mental illnesses, for other kinds of health problems. I mean, we used to have this joke among particularly trans women will tell you this joke in the context of HIV, that we get seen only as people who are possible carriers of HIV. So when we go into a public health system, all they want to do is HIV testing or STI testing. But I could be having cold and cough, and I would like that to be addressed. You know, I'm like a human being. I'm not just somebody who's a sexually active person and you're TI, targeted intervention person. So yeah, so medicos actually, the whole healthcare system poses major barriers to be able to for trans people or queer people to access. We know about infrastructural barriers like there being only male wards and female wards. Women not being, cis women not being comfortable with trans women being admitted in the female ward. The kinds of work that needs to happen with class 4 employees, nursing staff, who will provide care to a body that is traditionally seen in a particular way, but the person says, I'm a man, I'm a trans man, but somebody who may have not completed the transition or may have had some transition experience. So do they get attended to by male nurse, female nurse? There are a bunch of these kinds of system questions, actual treatment questions, service questions, all of this. So I think we can start with saying how does my hospital or my clinic treat queer and trans folks? And if we say that queer and trans people don't come to my healthcare setting, again ask, do they tell you? They probably don't tell you that they are queer or trans because they just don't see any image which tells them it's okay to be themselves in your setting. So do take a look at this queer affirmative counseling practice resource book for mental health professionals that we have written, which has a whole thing on how to make your setup queer and trans affirmative.
Is there a space for research as well? I mean, I think as you pointed out, there's lots of space for medical providers to educate themselves.
What are we doing wrong? We can start from there. What are we doing wrong is something we can actually document. We can also document what are the issues with which people are coming to us. Where are the barriers to care? What are the challenges? If there are dropouts, what are some of the possible reasons? If there are health conditions, mental health conditions with which people are reporting, what are some of the social determinants? These are all possibilities, particularly for healthcare providers.
Okay, I think, like I said, we'll share the comments and the Q&As with you separately, but I think we have covered a lot and we're also running out of time, and you've, for an hour and a half, I think you've been
I can't believe that. Yeah, about 57.
A healthy number have stayed through the end, which speaks a lot to both the topic and how articulate you've been in sort of, going through all of these issues and being generous in your answers as well. So on behalf of all the attendees and the Ramalinga Swami Center, I want to thank you very, very much for this excellent session. I almost feel like there should be a part 2 to sort of unpack some of these issues even further, but I'm glad we were able to do so in the Q&A. Thank you so much for your time, KP.
Thank you. Thank you.